Hello, everybody. My name is Brad Needleman. I'm a bariatric surgeon at The Ohio State University Wexner Medical Center. I'd like to thank Doctors Noria and Spaniolos, as well as Sages, for the invitation to give this talk. Sorry, I missed everybody this year in Cleveland, Ohio. My talk is titled Zebras and Horses, Beware Atypical Anatomy, but Don't Forget the Basics. The description of this talk is to present to non-bariatric surgeons some of the surgical emergencies that we might see that are not necessarily bariatric related, but occur in bariatric patients. Here are my disclosures. So non-bariatric surgical disease in bariatric patients, most often the surgical problems that we see in bariatric patients who present to the emergency room are really related to that operation. The most common complications, such as things as marginal ulcers, nausea, vomiting, dehydration, malnutrition, tend to be bariatric related. However, don't forget that anything that can go wrong in the abdomen can still go wrong even after bariatric surgery, whether it involves the colon or appendix, small bowel, biliary tree, etc. Obesity is a risk factor for many surgical diseases, whether it's biliary disease, cancer, ischemia. So it's important to remember what's going to happen most commonly in these patients, regardless of what operation they've had before. But it is important to know what operation that they had, whether it was a gastric bypass or duodenal switch or a lap band or a sleeve. That'll really help you with surgical planning. And if you don't have the operative records from if it was done somewhere else, understanding that the variances of the operations and how they're performed will really make a difference for what you find in the operating room. For example, in a gastric bypass, if somebody's had a retrocolic or retrogastric rulim, that may be very different than if they had an anticolic or an antigastric rulim. It can be confusing sometimes when you're in there trying to figure out the anatomy, not knowing that the rulim can be posterior to the remnant stomach or colon, and not even think that they've had a bariatric operation just based on that anatomy. So it definitely is important to understand those variations and what can go wrong with them. Like any other patient, bariatric patients have typical presentations of surgical emergencies, whether it's abdominal pain, free air, bowel obstructions, and nausea or vomiting. Sometimes when you're evaluating these patients, there will be different complications from the operation based on whether this is early or late post-op. Obviously, the massive weight loss we can see after bariatric surgery may make them more susceptible to different complications like internal hernias, or ischemia or volvulus, and what operation they've had obviously will play a role in their evaluation as well. I also think it's really important to ask them what previous complications from their bariatric operation they might have had. For example, patients with marginal ulcers, if they have another marginal ulcer, the presentation seems to be pretty similar. They'll know what marginal ulcer pain feels like. They'll know what a bowel obstruction feels like, and they can tell you if this pain is the same or similar or different. If they say this is nothing like my marginal ulcer pain, it's probably not a marginal ulcer at this presentation, and start looking for other things. Obviously, surgical emergencies, for example, in a gastric bypass, the most common probably things that we'll see are marginal ulcers and bowel obstructions. The marginal ulcers will all sort of present as pain and vomiting, can be a bleed, can be a perforation, and bowel obstructions are typically from internal hernias and intussusception. The most common things, though, that we'll see that are non-bariatric kind of related would be biliary disease, whether it's biliary colic or cholecystitis. And these sometimes can happen early or late. Pancreatitis can be an issue sometimes, stones or alcohol. Think peptic ulcer disease. We talk about marginal ulcers, but you can still get ulcer disease or gastritis in the stomach. And if you have bleeding or perforation, don't forget about that area as well. Bowel obstructions, cancers, which are common in obesity, appendicitis, inflammatory bowel disease, diverticulitis. We see these in bariatric patients, and they're not necessarily related to the bariatric operation. Obviously, I think we all see patients in the emergency room, and certainly we see our fair share of obesity, whether or not patients are bariatric patients or not. as everybody knows, examining a patient who's got a really large abdomen can be difficult. It can be difficult to elicit peritonitis. It can be difficult to elicit masses. It may not even be able to tell if somebody's actually distended from an obstruction due to the size of their abdomen. The thickness of the abdominal wall makes it really hard sometimes to differentiate a rigid abdomen from a soft abdomen. The other thing that I wanted to mention, because I see this not uncommonly, when a resident calls me in the middle of the night, they'll say, well, the CT shows a swirl, but their belly's pretty soft and non-tender. And don't forget that, ischemia is pain out of proportion. So their exams could be relatively unimpressive, but can still have some serious ischemia going on. Because of the difficulty with the exam, we tend to rely pretty heavily on imaging, which obviously can be a concern because there are some weight limits on some of the scanners and MRIs and things that we use to study these patients. It's not uncommon at a tertiary referral center like ours to get a transfer without a diagnosis, without being sure if it's even an emergency, but their scanner can't hold the patient and want to come here, so we'll use our equipment to help make a diagnosis. Far and away, I think the best test to rule out most surgical emergencies or life-threatening problems is a CT scan. It'll help you see the internal hernias, the ischemia, the perforation, the obstructions. It's very common these days to see a CT scan without oral contrast. I found those particularly unhelpful, and we'll almost often repeat that CT scan with PO contrast if they haven't performed that as well. Ultrasounds are not uncommon. Upper GIs are done pretty often. Abdominal series, I rarely use them other than to follow up the passage of contrast. If somebody looks like they have an obstruction or a partial obstruction, routine serial abdominal x-rays to see the passage of contrast I find helpful if I don't take that patient to the emergency room right away. Biliary colic by far is the most common thing that I'll see after bariatric surgery, that massive weight loss that we often see, that rapid weight loss right after surgery can lead to gallstone formation. It can present actually pretty early, even after the operation. It's not uncommon sometimes to see a patient a few weeks after surgery present with nausea, vomiting, dehydration. Just think it's related to the surgery. Forget to do that ultrasound, find stones, take their gallbladder out, and they feel better. As usual, it's postprandial epigastric pain, nausea, and vomiting. Can be very, very similar to a marginal ulcer and easy to miss if you're focused on that marginal ulcer all too much. I'm going to talk a little bit about ERCPs in the next slide, but just be aware that doing a postoperative ERCP is difficult. It's not just like, oh, there's a retained stone or a small stone or bile leak, etc. We have to do an ERCP post-op. It's a big intervention in somebody who's had a gastric bypass with a remnant stomach that's no longer attached. Not impossible. There's a lot of ways to do it. Can be done with double balloon or gate procedure or transgastric, again, which I'll talk about. But because of the difficulty in doing ERCPs, you should have a pretty low threshold for doing a cholangiogram. If there's any question at all, if there's anything in the common duct, that's the best time to figure it out. It's really helpful in my institution to have surgeons that do ERCPs because they're more comfortable in the OR and usually a little bit more available than my gastroenterology colleagues. Because of that, if there's question of a leak or other issues or stones in the duct, leaving a drain is important. And don't forget, it's not uncommon to do PTCs or cholecystostomy tubes in these patients. I much prefer doing an intraoperative ERCP at the time because those PTCs just have to be in for a long time, but can be done. Certainly those patients that present acutely with a common duct obstruction and sepsis, a PTC and a cholecystostomy tube is often a first line in a very obese patient or somebody who's had bariatric surgery to get them under control if you're not going to be able to handle the duct in the operating room. Like I mentioned before, ERCPs after gastric bypasses can be difficult. Most oftentimes here, we do them in the OR transgastric. They sometimes they already have their gallbladder out and have either retained stones, have a leak, or have primary common duct stones is something we've seen as well, and patient needs a ERCP. Some of the gastroenterologists can do them with a double balloon endoscopy. where as an image A up there, you can go through the roux limb all the way down to the JJ and back up the BP limb into the duodenum. In the handful of times that I've done these, I don't think it's been successful even 50% of the time. They have a really hard time getting up there. The scopes tend to be a little clumsy and they break pretty easily. Most of our endoscopists won't even try these anymore at my institution due to the difficulty and the low yield from doing it, but it definitely is possible to do. The other thing that's been relatively new is the gate procedure. As you could see from image B, C, and D, they basically pass a wire and then a stent, either from the roux limb into the remnant or from the pouch into the remnant, and then place a stent in there, pass the scope into the remnant, do the ERCP, pull it out, and then later pull the stent out. Obviously, there's a danger here of creating a permanent fistula between the two. The hope is that pulling that stent out, that hole will heal and the patient will return back to normal afterwards. I've only seen one patient have this done and the hole healed and they did well, but it's hard to find a gastroenterologist willing to do this procedure very often. Transgastric ERCP, like I said, is the most common thing that we do to help with stones and evaluate the common bile duct. My tricks into the trades or pearls for this is I typically try to put a 15mm port into the remnant. It's the ERCP scope's a big scope. You do less damage to the scope this way. I try to stay as high up on the remnant as possible. It's much easier for them to pass the scope down to the duodenum if you get high up on the stomach as possible. And I usually use some teeth fasteners or sutures in that to hold it onto the port so there isn't much moving around. That's usually pretty helpful. And then at the end, I just hold that up and I staple that hole closed. Like I said, the double ballooner gate procedures can be done as well. Free air, far and away the most common cause of free air in these patients is a perforated marginal ulcer. I hear often one of my ACS colleagues may call and say, free air, I can't find a marginal ulcer, scope the patient, can't see it. And you'll say, hey, did you look at the duodenum? Only to find out that there was a perforated duodenal ulcer. So what I always tell them is if you can't find a perforation along the GJ, even with endoscopic assistance, definitely explore the duodenum. And the second place I've seen perforations is from a gastric ulcer into the lesser sac, which can be really hard to see even in patients that haven't had bariatric surgery. But definitely exploring that and exploring the lesser sac is really helpful in doing that. And obviously it's the same as any other peptic ulcer disease. Usually gram patch those patients, usually enough for those folks. The nice part is because it's in a defunctionalized limb or defunctionalized remnant, you can feed these patients actually pretty quickly after this operation. You don't have to wait for it to heal. And I always try to tell people feel really strongly about placing a G-tube in these patients, mostly because it decompresses the remnant above the ulcer, especially if it's in the pylorus. The gastric ulcers, obviously, if you need to biopsy them and haven't done it, this gives you access to it later. You can definitely study the repairs with contrast before you pull the tube. Highly recommend placing gastrostomy tubes in the remnant after gastric bypass if you have a perforation in any of these areas as well. Bowel obstructions, I know there's another talk on these, but sort of the non-bariatric bowel obstructions tend to be adhesive obstructions, usually in the pelvis and distally. The most important thing I'll say about the bowel obstructions is really it's all about the remnant. If the remnant and BP limb are really, really dilated, I think that's a surgical emergency no matter where the obstruction is. You need to take those patients back to the OR. That's usually a closed loop obstruction, and when that remnant decides to perforate or blow out, that's pretty catastrophic. It's basically, and a 1.5 liters of biliopancreatic and acidic secretions being emptied into the abdomen pretty quickly, and those patients get sick very, very quickly. Otherwise, an distal adhesive obstruction is the same as any others, can be done laparoscopically or open. Usually it's the pretty straightforward operations, either from a previous hysterectomy or an appendectomy or something along those lines. Intussusception, we see this all the time on CT scans, usually it's incidental. In bariatrics, it can be seen at the JJ because it does get dilated over time, but can be found anywhere. I often won't rush those patients to the OR unless it's a complete obstruction or it's pretty large or there's evidence of ischemia. But my typical approach to this would be 2 films at 2 different times, showing it at the same location before I operate on them. You know, cancers too, it's not uncommon to see a bowel obstruction from a cancer, whether it's colon or small bowel or lymphoma. Work up some of these cancers can be hindered, especially a pancreatic cancer. Hard to do it's hard to do endoscopy to see that area, especially with an EUS, to get it where you would normally put it to evaluate that and biopsy that. So just be aware of that as well. Diagnose Crohn's fairly often in these patients as well. And especially those patients with constipation or other issues, colonic volvulus, especially with a massive weight loss and the bowel gets floppy, can be seen as well. But the treatments for all of these things in the operating room tend to be the same, whether they've had a bariatric operation or not. The tricky part gets in if you have to do a resection and reconstruction. And that's why understanding the anatomy is very important. And it's not uncommon for me to see somebody who's had dead bowel or mass who have it resected, they're left in discontinuity and sent to a tertiary referral center to put somebody back together. But definitely taking care of the acute surgical problem saved their life. And then later in a day or two, we can take those patients back to the OR and reconstruct them. The other common thing we see is paraesophageal hernias. They're treated pretty much the same as you would any other paraesophageal hernia. Sleeves, bypasses, anything. It's rare to have an emergent complication because they rarely go up there and volvulize. But you can see an obstruction from that sometimes too. Even a recent case of mine I think is worth mentioning is a large paraesophageal hernia that when you got into the abdomen, didn't look like there was a hernia there at all. And that was because the patient had a retrocolic retrogastric rulum. And so the remnant was in front of it, looked like it wasn't going up there at all, but the real hernia was behind that remnant, where the entire pouch, rulum, even the JJ was up in the chest, causing an obstruction and ischemia that required resection. That was a very difficult operation. Without knowing the rulum could be back there and getting to the lesser sac and reducing it, difficult operation. Like I said, we see pancreatitis. It's not uncommon for someone to ask me to help them evaluate the sphincter of Oddi for dysfunction, doing transgastric ERCPs, things like that. We see pseudocysts sometimes, which sometimes look like a perforation and abscess, but could be a pseudocyst from pancreatitis. The nice part is that remnant is a nice place to do a cyst gastrostomy. Our ACS surgeons tend to take care of appendicitis. His presentation is pretty similar and take care of the same way. Diverticulitis as well. So overall, I would say non-bariatric surgical emergencies in patients after bariatric surgeries can be more challenging to diagnose and treat due to the changes in anatomy and also the difficulties and challenges related to obesity. Definitely be aware of the different anatomic changes that we do in bariatric surgery from each kind of operations, but also the variations in each operation and how they're done. And then, and definitely think ahead about what could go wrong after the operations, what complications could you see, what could you need, and enteral access, especially after a bypass, putting a tube in that remnant will really make your life easier down the road, and is definitely worth the time in putting that in. It can always be removed as soon as you patient's better and you don't need it anymore. So thank you for listening to my talk, and hope to see you all in SAGES 2021.